I think we have conducted already the induction class or introduction class last week, and I couldn't take. So what I'll do is I will mute everyone for some time. Okay. And if anything, you can write in the chat box. Not a problem at all. Okay. So let's start the class. And today's class is very important. As I told in the induction class that we have, decided to take 8 to 10 class. But later I thought a lot and I decided to go slow. Doesn't matter if I have to take 12 or 15 classes. But I'll teach you this cardiac pharmacotherapy perfectly. Perfectly means really, like everything from the physiotherapy and drug by drug. So you can understand the things and it is, useful for all of you. Okay. So no hurry, like I'm not completing, because if I want to complete all the antiplatelet drugs in one class in 1.5 hours or 2 hours also, it won't be possible to understand because there are multiple classes, multiple drugs, multiple doses, contraindications and everything. And before that, there is pathophysiology, indications, and multiple other things to discuss. Right. So we will go slow. We will learn one by one. Right. So today we'll be talking about heart attack. Okay. Usually the myocardial infarction. And along with that, we'll be talking about the pathophysiology of clot formation. That is the base. If you understood this, at the end of the class, I'm very sure you will understand all the drug classes. Okay, all the drug classes. So let me share the screen and let's discuss it. Okay. So today we are going to discuss the antithrombotic agent and their pathophysiology and clot formation. So how does exactly the clot is formed and what are the drugs being used for that, right? And what are the reasons? Multiple things. So before starting this class, let me tell you guys, or let me ask you one question. Let me ask you one question that where do we, use the antithrombotic agent? In which conditions do we use the antithrombotic conditions? Okay, I have multiple questions, but I'll go one by one. Yes, please tell me, guys. Where do we use the antithrombotic agents? Yes, everyone. MI, stroke, DVT, angina, DVT, MI. Okay, MI. Right, ischemic stroke, MI. Okay, perfect. Yes, yes, yes. Okay, so usually when I'm talking about these antithrombotic drugs, when I'm talking about the antithrombotic drugs, so there are multiple indications, right? There are multiple indications. First is MI, right? That is myocardial ischemia, right? That is myocardial ischemia, right? And then second is stroke. Then third is DVT. DVT could be, either, atrial occlusion or venous occlusion. Okay, venous occlusion or arterial occlusion. Okay, but why we call it DVT only? Because here in the name that is deep vein thrombosis, but later they have changed it to PA. What is that? Peripheral artery occlusion or a peripheral arterial disease or peripheral ventricle occlusion or peripheral ventricle disease. Okay. So that could be either atrial occlusion or ventricular occlusion. When we are talking about peripheral, peripheral means it could be your arm also, it could be your leg also, it could be some carotid artery occlusion also. Not the stroke. Stroke is also kind of carotid artery occlusion only, but there are the subcarotid artery occlusions which comes under the peripheral occlusion. But usually in the peripheral, when we are talking about peripheral arterial disease, PAD or PVD, that is nothing but your upper limbs and lower limbs. Upper limbs means arms and lower limbs means your legs, right? And when we are talking about MI or stroke, so MI and stroke are directly, MI or stroke are nothing but two different system. MI is related to coronary arteries, okay, coronary arteries, and stroke is related to carotid artery, right? Carotid artery occlusion, right? And this is coronary artery occlusion. This is peripheral arterial occlusion or peripheral venous occlusion. That is DVT or peripheral arterial disease, PAD or PVD, right? So see, this is our circulatory system, which is divided into multiple parts, depending on the location. Depending on the location, if I am talking about liver, that is hepatovascular, okay. If I'm talking about kidney, that is renovascular. If I'm talking about heart, that is coronary artery or coronary vessels, okay. If I'm talking about our brain or our head or our neck, that is carotid system, carotid artery, right? Carotid artery or carotid vessels, right? So this is like all the vessels or the circulatory system is divided into different parts according to different systems, right? And different locations, nothing else, right? Along with that, if we talk about not only the indications, there are multiple other things. You have to think, you have to understand in two parts. Or let me ask you a question. Antithrombotic agents are prophylaxis or the treatment? Yes, guys, tell me. This is the question. Prophylaxis or treatment? What exactly is the antithrombotic agents? Tell me. Both. Prophylaxis, treatment, both. Okay. Prophylaxis, treatment, both. Okay. 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 What do you understand by prophylaxis, guys? Tell me. What do you understand by prophylaxis? What do you understand by prophylaxis? What do you understand by prophylaxis? Prevention. Preventing the future attack. Yes, preventing the future attack. Okay, preventing the future attack. Absolutely. I mean, preventing the future event, not attack, preventing the future events, anything. If we are giving the antibiotics, that is preventing the future infections. If we are giving the antiplatelets, these are for the prevention of future myocardial infarction or future infarction in at any place, right? And if we are giving some other drugs, that means we are you know uh, stopping the future events in certain cases, right? So that is called prophylaxis. Treatment means if something has happened already, and we are preventing that from growing, okay, we are preventing that from growing, or we are suppressing that to the actual whatever it was before, right? That means the treatment, right? And prophylaxis means we are preventing the future events, or we are preventing, like, maybe sometimes when it is the patient of myocardial infarction and we are giving the antiplatelet, that means we are treating itself, we are treating and we are stopping that to from the future events, right? So that can happen, and that can be done in different cases. So this is not only the prophylaxis but treatment also. So antithrombotic agents are prophylaxis and treatment both. So now let's before going to, because this is the title of today's as we can see here, thrombotic antithrombotic agent. So before going there, let's understand a little bit about heart, because there are many new people who are joining us today only. You guys know many people who are there with us from cardio series 1, cardio series 2, cardio series 3. You guys know what is heart and how it works, what are the systems, what are the chambers of the heart, and how the blood flows through the heart. So let me tell you again, just 2 minutes, let me tell you how the heart and carotid blood flow works and how these systems are involved in each other, right? So as you can see, this is nothing but your heart, and in that heart, if you see, let's start with this is right atrium, okay. This is right atrium, and this is your left atrium, okay. And this is your left ventricle, and this is your right ventricle. Okay, this is your right atrium and this is your right ventricle. This is your left atrium and this is your left ventricle, right, LV. So how the blood flow works? How the blood flow works? So there are two systems, you guys know that. First is oxygenated blood and second is deoxygenated blood, right? So oxygenated blood usually, our deoxygenated blood usually gets oxygenated with the help of lungs, right, in the lungs, with the help of alveoli and with the help of our breath with the air. So they get the oxygen, they absorb the oxygen from the alveoli in the lungs, and then the blood gets purified and get back to your heart, and from heart it goes to the body, and then from the body it comes back in the deoxygenated format to the heart, and in the heart again it will process to the lungs, and the same process works again and again. So let me make it very clear for you how it goes. So as you are seeing here, this part or this is one of the largest you know one of the largest vessel of our body, that is called as superior vena cava, or we can call it like the biggest venous vessel. Okay, so what exactly, why we are calling them vena cava, or why we are calling them venous system, why we are calling that venous system? Because this is containing the deoxygenated blood. Okay, deoxygenated blood, right? These are collecting the deoxygenated blood from all the systems of the body, from all the tissues, from all the cells, and these are aggregating the deoxygenated blood and getting to the heart. Okay, so it is like they are getting deoxygenated blood blue. Okay, that's why I'm denoting from the blue. So it is coming to the superior vena cava, and from the inferior vena cava which is coming from down, and superior vena cava which is coming from up, but it is collecting all the blood from the heart, and these are opening. Okay, these are opening into the right atrium. Okay, these are opening into the right atrium. So the first stop of the blood, deoxygenated blood, is nothing but your RA, right atrium. Okay, right atrium, and from right atrium the blood goes to right ventricle. The blood goes to right ventricle. Again, this is deoxygenated only. Okay, again this is deoxygenated only, and it goes to RV, right? It goes to RV from this valve. Okay, this valve is called as right atrioventricular valve because it is connecting the right atrium and right ventricle. It is connecting the right atrium and right ventricle, so we call it right atrioventricular valve. And this is tricuspid. Okay, this is tricuspid. Tricuspid means there are three leaflets. Okay, there are three leaflets which are you know which are actually the openings of the valve from right side to left, right atrium to right ventricle. So when it is opening, the blood goes from RA to RV, and it gets closed once the blood is passed completely with the heartbeat, right? And then this will not allow blood to come back to RA, right? So simple. Deoxygenated blood is coming to RA. From RA, through tricuspid valve, it is going to RV, and from RV our deoxygenated blood, is going to the lungs. Okay, it is going to the lungs with the help of left pulmonary artery to the left lung, and from the right pulmonary artery to the right lung. Okay, from left pulmonary artery to the left lung, and from right pulmonary artery to the right lung. So why we call them artery? Arteries are usually means that which are taking the blood out of the heart to the systems, to the different systems, right? That's why we call them artery. And venous means veins are which are collecting the blood from outside and getting into the heart, right? So usually veins are which are collecting the deoxygenated blood, and arteries are which are getting the oxygenated blood out of the heart. But here there is only one artery and one vein, one kind of vein and one kind of arteries which carry the opposite type of blood, and those are pulmonary arteries and pulmonary veins. Why we call them pulmonary artery here, why we call them pulmonary arteries? Because these are getting the blood out of the heart to the lungs, but these are also getting the deoxygenated blood. Okay, then it goes to the lungs, and in the lungs here, in the lungs, right and left lungs, it is getting purified. Okay, it is getting oxygenated, both the side it is getting oxygenated, and from here again the blood is entering, again from here the oxygenated blood is entering through the right, see, right pulmonary artery and left pulmonary artery to LA. Okay, this is oxygenated blood from the lungs, from the pulmonary veins. Why we are calling them veins? Because they are collecting the oxygenated blood from outside to the heart. But here, these are collecting the oxygenated blood. Okay, pulmonary veins. Otherwise, veins are collecting the deoxygenated blood from the entire body, from all the systems of the body, right? But in pulmonary cases, this is just opposite. Only in the pulmonaries, right? Because pulmonary arteries are getting the blood out of the heart, but that is deoxygenated to get it purified. And then pulmonary veins are collecting the purified blood or oxygenated blood from the lungs to the heart, right? So now this purified blood is there in the left atrium, and from here through the bicuspid valve. Okay, bicuspid valve or left AV valve, atrioventricular valve, atrioventricular valve, because this is connecting the LA and LV, left atrium and left ventricle, right? So this is coming to the left ventricle. The blood is coming to the left ventricle, which is oxygenated blood. Red, you can see here, this is oxygenated blood, and from here through the aortic valve, from here aortic valve are opening to the major artery of our body, that is also known as, what it is known as, ascending aorta. Okay, ascending aorta means which is actually majorly there are descending aorta also, but aorta is one of the biggest artery in our body, which is collecting the blood from left ventricle of the heart, which is purified, and then distributing towards the systems, like to all the systems, right? So from LV through the, our aortic valve, it is going to the where descending and ascending aorta. Okay, and from there are multiple branches which are distributing the blood to the entire body, right? So as you can see here, this is brachiocephalic artery, which is carrying the blood to the back side of the brain, and then left common carotid artery, okay, which is usually carrying the, again this is also carrying the blood to the brain. Subclavian is carrying the blood to where, guys? Subclavian, tell me from where, I mean to where the subclavian arteries are getting the blood? Right, the answer, left subclavian artery. Yes, tell me from where, I mean to where these subclavian arteries are getting the blood. Yes, anyone? Subclavian arteries, tell me. Upper limbs means your hands, your shoulder. Yes, it is. Okay, and so this is the usual blood flow in your coronary arteries and heart. This is the usual blood flow in your heart, right? Now let's talk about coronary blood flow. Let's talk about coronary blood flow. So here, see, this is the aorta. Let's continue with the aorta. This is the aorta, and from aorta, as we have seen, this is the common carotid artery. This is the common carotid artery, and these are the branches of coronary carotid arteries. These are the branches of carotid artery, but this is the main carotid artery, common carotid artery we call it. Okay, so from the aorta through the common carotid artery, the blood is going to the brain. Blood is going to the brain, right? And see how usually stroke happens. In the stroke, the blocks are usually generating, and blocks are created here. Blocks are created here, long, small, big. But here in the neck, this is the neck area. Okay, this is usually your neck area. Okay, this is usually your neck area. In this, you usually get the blocks or the thrombus, and that is leading to the ischemic stroke. This is leading to the ischemic stroke, not hemorrhagic stroke. Hemorrhagic stroke usually happens above the neck. Okay, this is the area of usually hemorrhagic stroke. Okay, hemorrhagic means blood clots happens in your brain. Okay, blood clots or thrombus happens in your brain, and that is called as hemorrhagic stroke. Okay, hemorrhagic stroke. Okay, hemorrhagic stroke. Okay, and this is the ischemic stroke. That there are two types of strokes, and management of these two strokes are totally different. Okay, and assessment of these two strokes are totally different. So, and management means the drugs we cannot give all the drugs in both type of stroke, so we have to choose the drugs depending. I'll teach that also. Stroke, I'll be taking one class on stroke as well, don't worry. And the management of hemorrhagic and ischemic stroke, those are totally different, but I'm just telling you what are the exact locations and how do we identify those things. Okay, how do we identify those things? So this is the area of hemorrhagic stroke, and this is the area, neck area is usually for the ischemic strokes. Okay, usually for the ischemic strokes, right? Hemorrhagic, no, that is different. That's not hemorrhagic exactly. So see, hypoxia is there in everything. Okay, hypoxia is the major reason. Once there is a block, once there is a thrombus, then definitely it will lead to hypoxia and then other symptoms. Okay, that is different part. But I'm telling why hemorrhagic there. This all is because of the thrombus formation. Okay, this all is because of the thrombus formation, right? So when I'm talking about the carotid part, so this is the common carotid artery, and to the frontal part of the brain, there is this artery. There is this artery. Okay, and which usually is anterior cerebral artery from here, not this one. This is going to the left shoulder and right shoulder. Okay, so this is the anterior cerebral artery, and this is middle cerebral artery, this is posterior cerebral artery and basilar artery, which are responsible to get the blood, or which are responsible to distribute the blood to the back of your brain. Okay, back of your head. This basilar artery and posterior cerebral artery are sending the blood or distributing the blood to your back of your brain. Okay, back of your head, right? So this is the carotid system, this is the heart system, and this is the usually blood flow to the both, right? So now when I was talking about antithrombotic therapy, so usually we give the antithrombotic therapy first of all as a prophylaxis also, and as a treatment as well, right? So as you can see here, to prevent the formation of blood clot or plaque, so that is nothing but the prophylactic management. Okay, prophylactic management. And then to dissolve the clot or plaque existed, that is the treatment, right? We are dissolving the plot, or dissolving the clot, right? So that means we have something which we can revert, which we can revert. So that is the treatment type of management, treatment type of strategy, and this is prophylaxis therapy. Okay, so usually antithrombotic agents, why we call them antithrombotic agents? Why we call them antithrombotic agents? Either these are preventing the new clots, or these are dissolving the existing clots. Okay, these are either dissolving the existing clots or preventing the new clot formation, right? That's why we call them antithrombotic. So see here, look at this. Thrombolysis in the patients with MI, the indications I was asking: ischemic stroke, not hemorrhagic stroke. Okay, not hemorrhagic strokes, ischemic strokes only. Subacute peripheral arterial thrombosis, PAD, massive pulmonary thrombosis or embolism, DVT, right? And thrombolysis of occluded hemodialysis shunts. So when usually there is the hemodialysis in CKD patients or AKD patients, acute kidney disease, or CKD patients, usually their thrombolysis, their hemodialysis shunts are getting blocked of the thrombus formation. Okay, so usually these drugs are also given to open the thrombodialysis or hemodialysis shunts in the CKD or AKD patients also. These are the major indications of antithrombolytic agents. Okay, like myocardial infarction means heart attack, any kind of heart attack, whether it is so there are multiple types of myocardial ischemia also. One is stable angina, right? Usually that is not, I mean, this is a type of heart attack also, right? And MI, this is then stable angina and unstable angina, right? This is unstable angina, right? And then there is what? STEMI, okay? STEMI and anstomy, right? So that is ST segment elevation MI, that is non-ST segment elevation MI based on ECGs. And this is stable angina and unstable angina. So stable angina means the pain is there, the pain in chest pain is there, but it is not needing any kind of urgent treatment. And major thing in stable angina is that the pain usually goes with the rest, okay, and it exert only when the person is exerting with the exercise or with the work or with the daily routines, right? And unstable angina means it occurs anytime, but it is kind of serious, so unstable angina also is categorized into the ACS. Okay, so ACS means acute coronary syndrome. It needs urgent treatment, it needs urgent attention from the cardiologist or from the physicians. Okay, and stable angina can be treated easily, can be diagnosed easily if you are going to the clinician or the clinics or the cardiologist. They will do one ECG, echo or treadmill test, and that can be done. But unstable angina, STEMI and unSTEMI are acute coronary syndrome usually. Okay, so these all are the indications for antithrombolytic agents. Now let me tell you what is the thrombogenesis or how the clot formation is happening. Okay, how these clot formations are happening, right? So let me add one more page and let me tell you how this clot formation is happening. Okay, so let's start here. Okay, so guys, what do you think, what is your opinion, how the clot formation will happen in your body or in your coronary arteries or in your DB or in your deep veins or in your peripheral arteries? How it happens usually? Tell me. Okay, let me tell you one thing. First, let me write the things here. First thing here is endothelial injury. Okay, injury. This is injury. Okay, and then it trigger the platelet aggregation. Okay, and it leads to the thrombus formation. Okay, it leads to the thrombus formation. Now tell me what happens one by one. Yes. Atherosclerosis, high cholesterol due to blood thickness, start with the endothelial dysfunction, rupture of already existing plaque formation, lipid deposition. Okay. See, let me tell you, thrombus generation or thrombus formation is the three-step procedure. Okay, it's the three-step procedure. One, the first procedure here is endothelial injury. Second process is platelet aggregation. Third process is thrombus formation. Okay, I mean how it ends with the thrombus formation. So let me tell you one thing, how the first step starts. Okay, how the first step starts. So this is our blood vessel. This is our blood vessel, right? And blood is flowing in this. Blood is flowing in this, and this is the this is the blood which is having the platelets, RBCs, okay, and multiple other things, right? So as we know about the vessels, how the vessels are created, the inner part, the inner layer of the vessel, right? This is the like full thick vessel, like multiple layers, right? This is the multiple layers of the vessel, right? So here when we are talking about one vessel, the inner lining of the vessel, this and this, this and this. So inner lining of the vessel is called as epithelial. Epithelial or epithelium. Okay, epithelial injury or epithelium, not endothelium, epithelium injury. Okay, right, guys. So you're telling me something? Lipid deposition, hemostasis, platelet plug formation, accumulation of lipid present in the artery, right? So this is epithelium, and is this epithelium or this epithelium? Yes, guys, please tell me. See, there are three layers in any vessel. Okay, there are three layers in any vessel. This is inner one, this is outer one. So which one is epithelium and which one is endothelium? Tell me. Inner one or outer one? Inner one is, just write, inner one is what? Inner one is endothelium. Inner one is endothelium. Exactly. So you should have stopped me when I was writing this intentionally, epithelium. You did not tell me what is that, sir. You are writing wrong. This is endothelium and outer one is epithelium. Okay. Why you're not stopping me when I'm doing something wrong intentionally or unintentionally? You should stop me, right? So this is endothelium. This is endothelium. See, guys, you should be very careful. See, I have written carefully here. Endothelial injury. Okay, so endothelial means the injury will not happen outside the vessel. Okay, outside the vessel, it will not happen. Okay, it will not happen. It will happen only inside the vessel. So this vessel wall is endothelium, and this is epithelium. Okay, this is epithelium. Okay, outer one. So what happens is, when I'm talking about endothelium injury, so let's see how it happens. Usually, what could be the, guys, tell me, what could be the reasons for endothelial injury? Inside this is the vessel, blood is flowing, certain other compounds are flowing, certain other elements are flowing. So why this injury happens? What are the root causes of this injury? What could be the possible causes of the injury? So tell me the possible causes of the injury. Possible causes or reasons of endothelial injury. Yes, guys, tell me, what are the possible reasons for endothelial injury? How it happens? Cholesterol plaques, high blood pressure, rupturing the cells, hypertension, smoking, inflammation, oxidative stress. Okay, very nice. See, oxidative stress, you went to the too much of what we say, pathophysiology, or too much of this mechanism. So first of all, it could be foreign elements. Okay, widely foreign elements. Foreign elements means either, suppose it could be fat molecules, we call them free fatty acids. Free fatty acids. That could be calcium plaques. Okay, that could be calcium plaques. Or what else? What else it could be? Toxins. Toxins means what? It could be alcohol. It could be if someone is taking the toxic substances, right? It could be let's write MDMA. It could be other toxins. Let's talk it toxins only. Let's not go into the deeper one. Toxins. Okay, so this is about foreign elements. This is about foreign elements, right? The second thing we can write is due to the endothelium inflammation. Okay, that inflammation could be because of the autoimmune diseases, genetic problems. Okay, genetic problems, or usually when the endothelium is very weak. Endothelium is very weak. So it can happen due to those things, right? And then there are, right? And then there are other things. There are certain other things. We call them comorbidities. Comorbidities. Okay. Comorbidities means diabetes. So there are diabetic platelets. Then hypertension. Hypertension is directly related to the endothelium rupture due to high resistance, due to very high resistance in coronary arteries. Okay, due to very high resistance in coronary arteries, right? Got it. Due to very high resistance in coronary artery, it can happen. Okay, and when we are talking about toxins and other things, someone has rightly mentioned, I forgot, and that is very important, that infections. Infections means virus, bacteria, dead bacteria cells. Okay, dead bacterial cells are also responsible, right? So these are multiple factors. Okay, these are multiple factors which are which are presenting inside your circulatory system. Now, out of circulatory system, what else you can think of, guys? What else you can think of? See, this is, see, this is let's give this one: foreign particles, endothelial inflammation, 3 is comorbidity, and 4 is what? Direct injuries. Direct injuries. How the direct injuries are happening, guys? First is, if someone is going through any kind of surgery or any kind of other problems where we are doing the catheterization. So what happens is catheterizations or catheters are directly responsible to injure the endothelium. Okay, catheters are directly associated with direct injuries to the endothelium. When we pass the catheter, we don't know where it is injuring the endothelium, because those are usually the metal wires. Okay, metal wires or fiber wires. So those can directly injure the vessel. Those can directly injure those things. Okay, this is when we are passing through the cardiac vessels or coronary arteries, right? Number 2 is, if something is happening somewhere else, SX surgeries. Okay, suppose there is one surgery going on in your brain, or there is one surgery going on, some amputation is going on in your leg. So what happens is, sometimes a little thrombus or little plaque, we call it plaque. Okay, when the blood clot is very small and it can float in our circulatory system, we call it plaque. Okay, we call it plaque, right? So when there is a small plaque that can travel to any areas, so some surgery is going on, some amputation is going on in your leg or arm or anywhere in the patients, or some surgery is going on in your brain. So what happens, sometimes a small plaque can travel through your arteries, can travel through your entire circulatory system, and that can come and stuck where? In your coronary artery, or anywhere else also, maybe in the carotid artery. So what it does, it gets stuck there, and it gets to the second phase that I am going to come now. Okay, so first thing is endothelial injury, and after endothelial injury, the second thing is platelet aggregation. Okay, second thing is platelet aggregation, right? So let's see here, or let's go back. Okay, let's go back and let's check here, right, guys? Let's check here. So see, first thing is, there are thrombogenesis or clot formation. There are 3 steps. One is endothelial injury, second is platelet activation and aggregation, and third is coagulation cascade, or your thrombus formation. Okay, coagulation cascade or thrombus formation. Okay, thrombus formation, right? So we have completed with endothelial injury here. Now we have to discuss platelet aggregation and activation. So look at this article, look at this picture. Let me make it a little small. Oh, sorry. Mm, mm. I hope the entire picture is visible to you guys. Is it visible? Emboli? Yeah. Is it visible to all of you? Okay, great. So when this, look at this. So the first step has happened already here. This is the site of injury. This is the site of injury where that vessel is injured, where that endothelium is injured. Okay, here it is the site of injury. So what happens when your endothelium is injured? What happens? Usually it secretes multiple elements. Okay, your endothelium, whenever it gets injured, it secretes multiple elements. Okay, multiple elements. And what are those elements? And what are those elements? See, this is, as we can see, this is VWF. Okay, so this is nothing but von Willebrand von factor. Okay, and then this is, this blue one is collagen. Okay, this is collagen. Okay, this is collagen. And when these gets secreted, these also, gets some type of coagulation factors with it. Okay, coagulation factors are also getting secreted with these. And what are those coagulation factors? Those are tissue factors and factor 7 and 9 of the coagulation cascade. Factor 7 and 9 and tissue factor. So this is also secreted, this is also secreted, this is also secreted at the injured site. This is secreted at the injured site. So first thing, let's understand once again. First thing is injury has happened, endothelium is injured, it has secreted multiple elements like Winwolfrand, von Willebrand, Willebrand factor, and then collagens, then tissue factors, then factor 7 and factor 9. Okay, this has secreted. Now what happens is, this is nothing but your entire vessel. Okay, this is nothing but your entire vessel, and here the blood is circulating. The blood is circulating, and blood is already having what? Blood is having what components, guys? Can you please tell me? RBCs, TLCs, or we call them WBCs, and platelets, right? Platelets. These are the major components, and then heme and all multiple things are there. Okay, multiple things are there, but these are the major elements of your blood which are there already. Okay, so what happens is these platelets are also flowing here. These platelets are also flowing here. So whenever these platelets come in the contact, with von Willebrand factor, VWN, von Willebrand factor. So this is von Willebrand factor. Okay, whenever these come in the touch of von Willebrand factor and collagen, what happens is these platelets get activated. Activated means they already have, see, like suppose this is the platelet. Okay, this is the platelet. Okay, so this platelet is simply, flowing in the blood, but at the surface of the platelet, already at the surface of the platelet, there is VWF factors. Okay, GP2, GP2, 3A fact receptors. Sorry, receptors. Okay, and von Willebrand factors receptors are there. So at the surface of this platelet, there are multiple factors receptors are available. Okay, multiple factors receptors. So receptors are already available here. So whenever they see that there are factors, these platelet is getting getting activated means these receptors are getting activated and getting attached with these factors, whatever were secreted from the injured site. Okay, so what happens is when the platelets are flowing, these will go to the injury site, and get attached with these factors. Okay, and start getting aggregated at that site. Okay, start getting aggregated at that site, right? So, now when the platelets are aggregating, platelets got activated. Now, whichever is coming to that site are getting activated and getting aggregated. Activation and aggregation is the second phenomena in that. After endothelial injury, second phenomena is platelet activation and aggregation. So now platelet aggregation is going on. All the platelets are coming to the site and aggregated at the site of injury, right? And then slowly the plaque has started forming. Okay, plaque formation has started. So see, now there is a look at this, see here, this is the blood vessel inside. Injury has happened, platelets are coming, getting aggregated, platelets are coming, getting aggregated, platelets are coming, getting aggregated. So right now when I'm talking, platelets are just coming, activating and aggregating here. So this plaque is softened, this plaque is very soft because only platelets are getting aggregated here, right? But the other particles also which are flowing nearby, other particles also which are flowing nearby, like calcium ions, okay, and free fatty acids, okay, and other like dead items means it could be bacteria, virus, rbcs, dead rbcs, other platelets, they are also coming and started aggregating here in this. So they are not getting activated and all, but they are just getting stuck in this platelet mass. These items are also getting stuck in this platelet mass and making this plaque strong. Okay, this is one phenomena. Still this plaque is very soft. Still this plaque is very soft until and unless the second phenomena, which is also known as coagulation cascade, has started, because there were some tissue factors also, factor 7 and factor 9 also. So these all three factors also get activated, and these three factors also started converting. Okay, started converting into what? So here look at this. Tissue factor usually convert factor 7 and factor 9 into activated factors. Usually these activate these things. Okay, so factor 7 is getting activated and turned into okay, I mean this factor 7 is getting activated, factor 9 is getting activated. So this is the form of like factor ix activated. Factor ix means factor 9 activated. This is factor 7 activated. Tissue factor is activated now, and these all are converting factor X, which is already there in your blood circulation. Factor X is inactivated in your blood, in your circulation system. Factor X is already available in your circulatory system, in your blood. So factor 7 and factor 9, activated one, are activating factor X into factor XA. Okay, factor X into factor XA, and then factor XA is converting thrombin into prothrombin, which is also available in your blood. Okay, so prothrombin to thrombin. This factor X is again activated, and factor X, factor 10 activated, is converting prothrombin to thrombin, right? And this thrombin is converted into this thrombin is converting fibrinogen, which is also presented in your blood system, in your circulatory system. This is activating fibrinogen into fibrin, and fibrin means the mass. Okay, fibrin means the mass. So whenever fibrin is there, it will coming to your platelet aggregation site and it will tighten the bond. Fibrin means mass. It will tighten the bond. It will bind all the platelets and all the things which are coming here. It will bind and make it tight, tight bond. Okay, make it tight. The plaque is now kind of unbreakable, or it is not easily dissolvable. Okay, this is because of the fibrin. So usually what has happened here, first of all, there was factor X. Okay, factor X was converted into XA, like the activated, and factor X converted our prothrombin, which is pro hormone of thrombin, and it has converted to thrombin, and thrombin is converting fibrinogen to fibrin. Okay, and this fibrin is going here and making this mass strong. Okay, so this is now the strong plaque. This is called the plaque formation or clot formation. Okay, now the clot has formed at the injured site and it is getting bigger, it is getting bigger, it is getting bigger, and creating the creating the hindrances in the blood flow, and that is called heart attack. That is called the condition hypoxia, and the blood flow is stopped either or partially stopped or completely stopped, and then the people get heart attack or stroke, right? So that is the condition how the clot is formed, right? So now the thing is, clot formation is in some patients it is very fast, in some patients it is very slow, right? So depending on that only, we define it as the normal coronary artery disease or ACS, acute coronary syndrome. So acute coronary syndrome means this plaque getting that this plaque is formed only within minutes. Okay, that's why we need patients to reach hospital as soon as possible, because this plaque is forming as faster as anything. Okay, and that can kill the patients within minutes, within hours. Okay, I mean it takes just minutes to get strengthened and to stop the complete blood flow in the vessel. Okay, so this is how it gets done. Okay, this is how it gets done. You can see here, see again, I'll just repeat it once. Site injury, platelet aggregation, I mean activation and aggregation, parallelly the tissue factor and the coagulation cascade is going on. So this side platelets are aggregated here, and this side fibrin is coming to this aggregated platelets and making the plaque tighten. Okay, and this is called as thrombus or the plaque. Got it? So that's how it is being done, and that's how it is causing the problem, right? So now very simple question for you all, and I'll ask you the questions also. Sir, what is meant by silent MI? Silent MI is nothing but when the people usually do not get the symptoms, and symptoms mainly the chest pain. Okay, so only 95% people get the only 95 people person 95 people or 95% people get the the all the chest pain and everything. Okay, 95 to 98% usually gets that. Otherwise 1% people. And silent MI means when people are not getting the chest pain, and that is also severe, so people sometimes miss that chest pain in the gastritis, or maybe they get what we say confused with the other kind of pains in that. Okay, how do we know the clot is formed fast or slow? ECG is there and symptoms are there. If you get the heart attack symptoms, then you can easily you can find out and you can rush to the hospital, right? The symptoms tell you that it is faster or slower. Exactly, you can get the symptoms on that. Role of cholesterol in plaque formation. Of course, plaque formation is one of the reason for site injury, as I told. The free fatty acids, the cholesterol free fatty acids are the major reasons, one of the major reasons as foreign particles to injure the endothelium. Okay, and then even the free fatty acids and calcium particles, as I told here, look at this here, these are also very much helpful in tightening and aggregating in the platelet mass. Okay, in the platelet aggregation, so these are also very important. So the people who are fat, literally who are fat or who are having high free fatty acids or LDL or VLDL, very low density lipids, those are having more free fatty acids in the circulatory system. Understand that why we call them low molecular weight LDLs. Why we call them very low molecular weight or very low density? Why we call them very low density? Because they are more what we say more prone to flow or more prone to float in the circulatory system, and whenever there are the chances they get the vessel injured, and they are the most what we say elements which comes into the plaque, right? Calcium ions and free fatty acids. Okay, that is the role of cholesterol in plaque formation. Do we have endangered endogenous platelet aggregation inhibitors? We have. Okay, can clot formation be asymptomatic? Clot formation is always asymptomatic. That is just because of the hypoxia you get the chest pain. Okay, that is because of the hypoxia you get the chest pain, because when your heart has to work hard and your heart has to work enough and you are not getting the enough oxygen, that calls to the chest pain. Okay. Okay, so my questions here are, when I'm talking about factor X, factor 7, factor 9, factor 10, these are the factors assigned symbols. Okay, these are the factors assigned symbols, but there are some names to those factors. There are some names to those factors. So can you tell me what is the name of factor 10? And what's the name of factor 9? What's the name of factor 7? Can you please tell me? And what's the name of factor 4, 5 also? Factor 5, factor 7, factor 9, factor 10. 10 is Stuart power factor. Yes, perfectly fine. Not power factor. Stuart power, nahi, Stuart power factor. Okay. Factor 5 is labile. Christmas factor is 9. Yes. Hagman factor is factor 7. Sorry, 12. Okay. Right. So look at this. Look at this. Here are the all names. Okay. So factor 1 is fibrinogen. Okay. Factor 1 is fibrinogen. Factor 2 is prothrombin. Factor 3 is thromboplastin. Okay. Factor 4 is calcium ions. Factor 5 is labile factor. Factor 7 is stable factor. Factor 8 is anti-hemophilic factor. It usually have been seen in the hemophilias. Okay, and factor 9 is also known as plasma thromboplastin components, PTC, or Christmas factors. Okay, Christmas factors. Factor 10 is Stuart Prower factor. Factor 11 is plasma thromboplastin antecedent. So that is PTA also. Okay, and then factor 12 is Hagman, and factor 13 is fibrin stabilizing factor. So that is the antigen of factor 1. Factor 13 is antigen of factor 1. Okay, antigen means factor fibrin stabilizing factor always stops the fibrin. Okay, fibrin formation usually, right? So they have the different roles and responsibilities in your coagulation factor, and all the clotting factors are not involved in the clotting cascade as well. Okay. Okay, guys. So usually, as we have seen, factor 1, factor 5, factor 7, factor 9, factor 10 are involved in the clotting cascade and in the antiplatelet aggregation and clot formation. Right, guys? So as we have seen, this is the major pathophysiology of the clot formation. I hope you understood that. Along with that, now let's talk about what are the antithrombotic drugs. There are three types of antithrombotic drugs, guys. There are three types of antithrombotic drugs. One is anticoagulant, one is antiplatelets, one is fibrinolytics. Okay. Now there are the questions. Anticoagulants. Let's talk about anticoagulants. What are the anticoagulant drugs, guys? Tell me, what are the anticoagulant drugs? Heparin, okay. Heparin and warfarin, heparin, low molecular weight heparin, enoxaparin. Are these are rivaroxaban, streptokinase. Oof. Okay. Okay, tell me one thing. Okay. Indendione derivatives, which affect and alter the coagulation process. Deltapren, Ixiana, dabigatran lextate, dabigatran, okay, streptokinases, fibrinolytin. Okay. So what's the difference between anticoagulants and fibrinolytics, guys? Tell me, what's the different difference between anticoagulants and fibrinolytics? Tell me. Acha, tell me, anticoagulants are prophylactics or treatment? Anticoagulants are prophylactic or the treatment? when I'm asking about anticoagulants, those are what? Warfarin, azithromycin, enoxaparin, right? Heparin, rivaroxaban, other banes, right? So anticoagulants usually means these are stopping the formation of clot. Okay, these are stopping the formation of clots. But fibrinolytics means which are dissolving the established clot. Okay, fibrinolytics means dissolving the established clot. So usually anticoagulants are preventive therapy. Okay, anticoagulants are all preventive therapy. Okay, prophylaxis we can say in the another terms, preventive therapy. Okay, heparin and enoxaparin usually sometimes used to dissolve the clots also, so these are called as preventive therapy. Prophylactic and treatment both, yes, but anticoagulants are preventive therapy and fibrinolytics are to dissolve the existing clots. Okay, dissolve the existing clots. And what about antiplatelets, guys? What about antiplatelets? What do you tell about antiplatelets? What do you think about antiplatelets? Prophylactic or treatment? Antiplatelets. What is thins the blood? There is no blood thin. Treatment. Treatment. Okay. So do you think antiplatelets are, I mean, you think antiplatelets are all treatment, right? Antiplatelets are treatment. But let me tell you, see, antiplatelets are always preventive medicines. Okay, you don't give antiplatelets to dissolve the clot. Okay, these are just to prevent the formation of clot and given after or when we have the patients with high risk of clot formation. Okay, so usually the prevention and prophylactic antiplatelets are mostly prophylactics. Okay, in all the cases almost prophylaxis antiplatelets. Okay, not exactly dissolving any kind of existed clots. Okay, antiplatelets are usually stopping the further clot formation or the new clot formations. Okay, so these are the preventive therapies, and fibrinolytics are the treatment or the what? No prophylaxis. Fibrinolytics are never been the prophylaxis. These are the treatments. Anticoagulants could be both, but antiplatelets are purely prophylaxis. Purely prophylaxis. So, guys, now tell me what exactly you have seen the entire cascade. You have seen the entire pathophysiology. Entire pathophysiology. Let me erase it. Let me erase it. So now you can, now you can usually understand and tell me also. Last question of this class. Okay, you can tell me also that easily. I'll not delete everything. Mess, yeah, I think someone has corrected me in the mess spelling also. Yes, that is MESH, not MESS, but usually MESS is also the quite messy. Okay, but that is MESH, right? Okay, so now tell me, guys, look at this entire picture. Look at this entire picture. Okay, look at this entire picture and tell me where does these antiplatelets will work, where these antiplatelets will work and where these antithrombotics will work, right? See, all three anticoagulants, antiplatelets will work. Tell me, guys. Yes. at platelet receptor site inhibit prothrombin. No, one by one. Let's talk about the antiplatelets. Where these antiplatelets will work? Antiplatelets will work. Where? Okay. So antiplatelets I'm talking about. So where it will work? Maybe the process platelet, platelet activation, right? As per your answers, I can write activation and aggregation, right? So majorly the antiplatelets will prevent antiplatelet activation and antiplatelet aggregation, right? Antiplatelet drugs will work on the activation prohibition or aggregation prohibition, right? And then definitely it will stop the coagulation or stop the entire plaque formation, right? Entire plaque formation. Definitely we'll talk one by one because there are multiple types of antiplatelets as well. Can someone write what are the types of antiplatelets? What are the types of, okay, do you guys have written already GP2B3A inhibitors and thromboxane A2, okay, platelet aggregation, thromboxane A2, so COX inhibitors we are talking about. So tell me the classes of antiplatelet drugs, guys, here. Tell me the classes of antiplatelet drugs here. Yes, tell me the classes of antiplatelet drugs. P2Y12 inhibitors. P2Y12 inhibitors are what? Okay, let me write the classes of antiplatelet drugs. Let me write the classes of antiplatelet drugs. Antiplatelet drugs classes. One, someone told me P2Y12 inhibitors. Okay. And someone has told me GP2-3A, GP2B-3A inhibitors. Right? And PD inhibitors. Okay. PD inhibitors. PDE inhibitors. What are the examples of P2Y12, GP2B3A inhibitors and PDE inhibitors, guys? Tell me the examples also 1, 1, 2, 2. Then everyone will understand. Definitely we will discuss in the next classes. Okay. ADP receptor antagonist, COX inhibitors. Okay. Phosphodiesterase, PDE, yes. Ticlopidine, clopidogrel, prasugrel. Okay. So main thing I think forget COX inhibitors. Okay. Give me the example of COX inhibitors as well. Give me the example of COX inhibitor as well. Aspirin. So COX inhibitor is nothing but aspirin. Okay. And PDE inhibitors are what? GP2A inhibitors are what? PD. Okay. So P2Y12 inhibitors are clopidogrel, ticlopidine, prasugrel, and new is ticagrelor. Okay. Clopidogrel, ticagrelor, prasugrel, and ticlopidine. These are the P2Y12 inhibitors. What are PD inhibitors and what are COX inhibitor? COX inhibitor is aspirin. What are PD inhibitors, guys? Tell me what are PD inhibitors? Okay, dipyridamol is PDE inhibitor. Okay, GP2B. Okay, GP2A 3B inhibitors are tyrofibin. Okay, perfect. Tyrofibin and okay, and okay. So see, guys, look at this. Anticoagulants are effective in the prevention and treatment of thrombus in venous and arterial system. As I told, these are the prophylaxis and treatment both. These are only the prophylaxis. Antiplatelet drugs are generally only considered for atrial and intracardiac thrombosis as these thrombi are rich in platelet with thrombi emboli. So these are usually to stop or prevent. Fibrinolytics are to dissolve the existing thrombus and ideally used as the chronic, used for the acute treatment of thrombosis. Acute treatment of thrombosis. So these are the three categories and we'll be talking about these one by one in our upcoming classes. So now I'll stop the slides here, guys. Now I'm open to the questions. If any questions, please ask your questions, guys. Questions, please. Yes, questions. Any question? Okay. Which drug we have give in first clotting case among all these? That I'll tell you. That I'll tell you, Arun. Usually fibrinolytics we give if the treatment is not available, if the catheterization lab is not available immediately, if the interventional lab are not available immediately, then usually we give fibrinolytics. Okay. Why does patients on anticoagulant still suffer from heart attack? Well, number one root cause for this is medication non-compliance. Even a single dose of antiplatelet drugs missing can cause the heart attack again. Okay, so people who miss the aspirin, ticagrelor, or whatever they are on, if they miss the single dose, they can get the heart attack, and they are the more prone. So why does this question Isa Samreen is asking? So the first thing is non-compliance to the drugs. Okay, and then there are other things. Other things means some patients are not tolerating those drugs. Some patients are having hypercoagulability. Hypercoagulability means they are secreting the coagulation factors very in the high level, right? So hypercoagulability is another reason, but the first reason is the medication non-compliance. Hemorrhagic stroke and other things I'll tell in the specific classes, guys. Don't worry, otherwise you will be missed the things. First line treatment for ACS, aspirin, clopidogrel. I mean P2Y12 inhibitors, tricagrelor. There are different drugs, guys. Different drugs. I'll tell you one by one. Usually the aspirin and the P2Y12 emitters, then atorvastatin, and along with that multiple things. First line therapy is the personalized therapy here. Okay, here we have personalized therapy when I'm talking about pharmacotherapy or cardiac problems. These are the things. Major side effect of anticoagulants, I'll tell. Bleeding is first, and then there are other things as well. I'll tell all the things in the classes and with all the drugs, guys. Major side effect of anticoagulants is bleeding. Okay. Why more than one antiplatelet is given to a patient who is suffering from the heart attack? That's very important question, guys. That's very important. That's very important question. Why it is? Because aspirin only prevents the COX. Okay, aspirin inhibits only the COX, not P2Y12. Okay, so we need P2Y12 inhibition as well along with the COX inhibition to prevent the percentage of the prevention. So COX inhibition is preventing around 60 to 70% of the clot formation, and then 20% is because of P2Y12. Okay, so this is the reason why we give two drugs altogether to prevent the clot, right? We usually should give three actually, but that 7 to 8% is like not in the risk management and not in the risk benefit ratio. Okay, so usually we give two, so we can reach up to 80 to 90% of the clot formation prevention. Those two drugs are having two different distinguished mechanisms. Okay, any resources you would suggest us to read to understand the upcoming topics better to or refer to? I will share in the class group. I'll share in the class group. Okay, I'll share in the class group. Okay, so thank you very much, guys. It was a nice class and I think nice start. Okay, take care and we'll see you on the Tuesday. Tuesday is our class, right? Tuesday is our class, correct? So we'll see you on the Tuesday, day after tomorrow. Take care, guys. Take care. Thank you. Thank you, everyone.